I'm happy to share the session with Mr. Antonio Kalil, my dear colleague. I know that Mr. Kato is still on the flight coming from New York, so he's a little bit late. And I'm very happy to ask for our first presentator, Eduardo de Santibáñez from Argentina.
Thank you very much, Jina. Thank you very much, Dr. Bismuth, Guido Torsili, and all the rest of the company. The goal of present this case is just to show the natural evolution of a cystic disease, and also to point it out in a very rare complication. This is the case of a 41-year-old female that was treated in 2009 in Mar del Plata. It's a city in the coast of Argentina, and they performed a laparoscopic cholecystectomy, and in 2010, after a cholestatic episode, she received an RCP and papillotomia, and the endoscopy says that they obtained some detritus and membrane extraction from the bile duct. Regarding the membrane extraction, as Rodolfo Russi has said, in Argentina, the hydatidtic cyst with communication in the bile duct is common, so the endoscopy thought it can be an hydatidtic cyst in communication with the bile duct, as you can see in this image. But the serology was negative, and the patient received treatment with albendazole. 8 years later, in Spain, she had abdominal pain, and they performed a CT scan, and they found a 13 centimeters polymorphic cystic lesion. This is all the information we can get, and also we don't know how, when she was treated in Argentina 8 years before, she had not, they didn't perform a CT scan. They performed just an ultrasonography. And then they assume that the patient has an hydatidtic cyst. 1 year later, in Marbella, she again has asthenia, fever, chills, jaundice, abdominal pain, and she was inflamed, cholestatic. All the serology for hydatidtic cyst and for parasitic disease were negative, and she was treated with antibiotics, and again, they provide albendazole to the patient. Was not possible for us to obtain the CT scan, but they describe an hepatic lesion that continues growing and was cystic in nature with enhancing septa upon constant administration, involving segment 4, 5, 8, 7, part 2 and 3, with intrahepatic vascular displaced by the lesion, intrahepatic bile duct dilated due to compression, and normal caliber of the common bile duct. They decide that the lesion was not resectable, and they referred the patient to a transplant center. In that occasion, the patient still had the relatives in Argentina, so she moved to Argentina and asked a second opinion at our hospital. The patient was asymptomatic, but looks like she was a 6 months pregnancy. So we performed this CT scan. You can see that the imaging has still growing, and also that it has inside some tissue, papillas or whatever. It don't look for us that it was an idiatic disease. The patient felt discomfort, but was not impregnant, don't look to have a malignant disease. Sorry. These are some of the images. Here you can see that also segment 2 and 3 were invaded, and the intrahepatic bile duct was, this is the MRI. You can see the dilated bile duct and the enhancement of these papillas. It was something similar that we had been seeing this morning. So, in order we decided that this patient was, the only solution was a surgical resection. And the problem, and we assume that the disease has already performed a vascular deprivation. We published this paper some years ago regarding to evaluate, to avoid the post-hepatectomy liver failure, and we find that the IVA index, what is Ospedale Italiano index, has more specificity than the index of the Academic Medical Center of Amsterdam, the percentage of count, and the key number is more than 15. So this patient with the hepatic scintigraphy with meborofenin has an IVA index of segment 2 and 3 of 24. So 24 is very good because you have enough index in case that you have a complication. That's what, but sometimes it happens not only in a complication nor in the Klatskin tumor, the residual parenchyma is not always enough. So we perform, as soon as we enter, a frozen intraoperative biopsy, and they informed that was a cholangiocarcinoma. So we perform extended right hepatic trisegmentectomy and extended to segment 2 and 3. Here you can see that we resect the ducts of segment 2 and 3, resection of the caudal lobe, also of the extrahepatic bile duct in case that the patient has a multicentric disease, and a bicholangiojejunum anastomosis and hepatic lymphadenectomy. This is the row I always perform after I finish a procedure. And I think that what I put here is not the last version. It's an old version, but it's okay. So the pathology is open in the operative theater of the tumor. You can see the mucinous content and also the papilla. It was not nice, the aspect of this tumor. So before say is an intraductal papillar neoplasm of bile duct with mixed immunophenotype, had 2 or 3 of the cell types associated with multifocal microinvasive carcinoma. The largest focus was 2 or 3 millimeters. This is very important for the prognosis. G1, mixed growth pattern, and mass formation and periductal infiltrative. The rest of the bile duct with high-grade dysplasia and carcinoma in situ. Negative lymph node, negative margin, PT1A, PN0, and no metastasis. You can see the mixed immunophenotype. So I look forward this, for the long-term prognosis in this case. I look for this paper from Kubota and Kondo, and it's one of the largest. It's 140 collected cases from Japan, and they found that, of course, the 4 phenotypes of the neoplasm, and they found that the prognosis was much better when the type was oncocytic type or gastric type, and the worst prognosis was for the pancreatobiliary type and intestinal type. This case was a mixed case. Now is the second part of the presentation. I don't know if you want to discuss anything about the case.
One question, Eduardo. Did you know, you knew what you were going to operate before? You had an idea of the diagnosis, or you just said this patient needs to have this type of a...
We suspect that the patient has an IPN biliary disease. And also we suspect, all the markers were negative, but we suspect for the enhancement of the papillas that maybe she has a malignant transformation, and in several places malignant transformation. So we were thinking like that the discussion with with Rodolfo. We were going to resect all the extrahepatic bile duct in order, and also perform a lymphadenectomy in this case.
Hugo, it's very interesting. My question is about the remaining bile ducts. So you had a lot of high-grade dysplasia in the tumor, but what about the rest of the bile duct that you resected?
The extrahepatic bile duct, almost all the extrahepatic bile duct was free of dysplasia and has not tumor, of course. That's the reason we perform a Kocher maneuver and ligate the bile duct as far as possible and send to the pathologist, of course. If it appears that we have a tumor or a dysplasia there, maybe in a second opportunity we'll perform a duodenopancreatectomy, because this procedure was very, very huge.
Okay.
Okay. As this patient entered in a protocol that we measure in this patient, we always measure after big procedures the portal pressure, and the portal pressure of this patient was 18 after we finished the procedure. So this patient entered in a protocol with terlipressin, and because we want to be sure that the portal vein flow will not decrease, and it can clot or thrombose. So Sofia did every day 3 ultrasonography. Yeah.
Hugo, it's better to finish and then we ask questions so that we can follow the history.
Okay, go ahead.
Okay, if you don't mind.
So 5 days later, in the postoperative course, Sofia informed us that the patient has pneumatosis, portal pneumatosis, and in that time the patient was good, but started to be a little encephalopathic, young lady. So what do you think means this, air in the portal.
To this, it's not very usual that you have 18 of portal pressure after a resection, because you left a lot of right liver, of liver after. This sometimes happens when you do a portal vein resection. Usually above 15, we don't like very much. We try to use or splenic artery ligation or a plasty of the portal vein. What do you think is the reason why the patient had such a high pressure after the resection?
Not idea, but Hugo, but we resect part of the segment 2 and 3, and when we collect the EVA index, it was to the full 2 and 3 segment. And maybe this is one. Also, the patient received several Pringle maneuver. I don't believe this can affect that, but the reason is the patient, we measure several times, we have the practice in doing that, and that's the reason that we put the patient on terlipressin.
Yeah.
Yeah. So, for you means something air in the portal vein? In the
Pietro.
Pietro. Micro.
With suffering of the intestine somewhere, in wherever,
well,
in fact,
yeah,
from the stomach, from the stomach.
Very good comment.
Edouard?
And I was driving when I received this information. So we,
Eduardo, just
CT scan,
how,
immediate
what
CT.
was the total of the clamping?
the total clamping, I think were three clamping.
3 clamp of 15 minutes each.
20 minutes the first, 15 minutes the last, with 5 times release.
Okay.
Then we say, what happened? The patient is a little encephalopathic and has pneumatosis portal, so let's perform a CT scan.
Yeah.
And the patient has intestinal pneumatosis, duodenal pneumatosis.
Huh?
So, what do you think, Guido?
Well, intestinal pneumatosis,
It's a sign of a bowel infarction, this is.
no, not always.
But it's in ultrasound, when you find, if you have an emergency, and we described that, when you see the bubble in the portal branches, there is high, it means that the bowel is suffering.
We published that you can see it in multiple conditions. Appendicitis is one of them. If you do a proper, and it's better visible on ultrasound than on CT, but it has to be taken extremely seriously. I would go back immediately to theater with this patient and check on the viability of the bowel. It's not always infarction. Some are reversible.
So,
And
we were very scared about that, you know, because in the time I went to the hospital to see the patient was Saturday, and I read something in internet what this means. And so we explore the patient, and the patient has a coliperitoneum, a bile leak from a bile duct in the tract section plane. So we closure, and we drainage the peritonitis, we clean the patient, and we pray. So
that never works.
So this is the surgical exploration, and you see after the exploration how all the inflammatory parameters goes up. And also the most sensible is the bilirubin. You see how the bilirubin goes up, but the patient improved his this is the quality, and as you will see, this was discharged in the 20 days post-operative. Everything looks okay here. And this is the patient with the scar here. Thank you.
Excellent, Eduardo.
Some comments?
I want to say something because this is the old presentation. When I passed from my memory stick, I put the old one. But there is a surgeon in Thailandia that you know that Thailandia is a place where there is a real important incidence of cholangiocarcinoma, very important, and of cystic inflammatory disease. So he has studied the natural evolution of this disease. I have the draw here of him, but I recommend it's a paper from Hepatology from 2021. And he studied all the evolution that Rodolfo explained today, what happened with the intrahepatic, the extrahepatic, and how it will grow. And how are the images that we can see? Because you can detect this disease maybe by an incidence, and the images are totally different, and you have to detect it. And this is a correlation between the evolution, the time of evolution, and the prognosis, and also the time of the evolution and the incidence of a positive lymph node that is that really darkens the prognosis.
Thank you, Eduardo. No other comments from the audience? Susan, yeah. The micro.
The first description of portal venous gas described on any imaging was in 1952, and it was due to ischemic bowel that caused portal venous gas to go into the small portal venules that was seen on a plain film, and the patient ended up having ischemic bowel and went to the operating room to have it resected. The way it was proven that it was portal venous gas that was seen on the plain film X-ray that had little sort of stippled gas in the periphery of the liver was when the patient went to the operating room, they took the mesentery out, they transilluminated it, and they saw little bubbles flowing up towards the liver, and that's how they proved that that's what it was. And that was, that paper, the first paper ever was my father wrote.
Okay.
Thank you.
Valerio.
I just have one question about the measurement of portal pressure, because I also measure always portal pressure and the gradient, and I put the cutoff of 20 to make measures, and we usually we give somatostatin during the operation and a couple of days afterwards. What is your threshold to do something, and how long do you pursue your measures?
In this protocol, we have been using terlipressin that we have used sometimes in small for size in liver-related transplant, and the cutoff is 17. Or sometimes the patients have a almost normal portal pressure, but develop ascites. In these cases, also, we use terlipressin for the treatment.
Thank you, Eduardo. Let's move to the next presentation by Henri Adam.
Good morning, everybody. Very happy to be with you. in this fantastic Congress Center. Many thanks to Guido Torzilli for welcoming us. Very good. So I will present you a case, but a case in my view that may us discuss about something possibly new. And the title you imagine, liver metastasis from esophageal cancer, always a contraindication. And so for that, yes, sorry. It was the case of a male of 68 years old. I don't go into all the detail that you can read very, very easily. Some comorbidity, but not so high. It's work. He has dysphagia and a weight loss of 22 kilo. And upper endoscopy was done, and he has not only one, but a double esophageal tumor at 40 and 45 centimeters from the dental arches. So double localization with a CEA at 711. At histology, it was not a squamous cell carcinoma, it was an adenocarcinoma. And at immunohistochemistry, it was R positive, sorry. And so he had a CT scan. It was outside our institution. So I don't know why they didn't do any injection, but you can see here four huge metastases, two on the right liver, one at the middle part in segment 4, another one in the left lobe. The PET FDG was done, didn't show any uptake, extraesophageal or hepatic uptake in addition to that. And so the first question, seeing this paper, is this patient marginally resectable or unresectable? I did not ask you the question, but anyway, if we see the French recommendation in digestive oncology, it is said that the main treatment in such case is the endoscopic treatment of dysphagia, and as possible, as much as possible, chemotherapy, and then discussing irradiation. And so it's what this patient received, because it was managed outside our hospital by a primary chemotherapy with 5-FU cisplatin and Herceptin. And after 10 courses of chemo, he had a significant improvement of the general status, good biological response. You see the decrease in CEA. At endoscopy, disappearance of the two esophageal lesions, biopsy, no tumoral cell, and imaging at 8 months. At that time, we had the possibility to do it much better. You can see a significant reduction of the size of the tumor here. Still the remaining 4 lesions, of course, but with a much lower size. And here you have on PET CT, the uptake of this lesion. And so, in summary, the report of this patient, double adenocarcinoma of the lower third of the esophagus, bilobar synchronous liver metastasis, excellent response to chemo, clinical, biological, endoscopic, and morphological, minus 68% of RECIST criteria. And so what to do? What to do? Do we continue the chemo, which is working very well? Do we propose esophageal surgery, liver surgery, combine both, stop and go for chemo? I let you give your opinion on that. What do you think? It's totally open because by definition it's what I may call a marginal case. So,
Eduardo.
We have had some experience in the Hospital Italiano, not so spectacular like this because the response is very important. But after chemo, we treat the esophagus. We we try a biological margin time to see, and then we perform, if it's possible, a liver resection.
So you stop the chemo before? I have not.
No. We made the full chemo. We resect the esophagus, and then 2-3 months later, we resect the liver metastasis.
Okay, it's a strategy. Eduardo, you want this? Yes.
Of specialization in surgery. I ask you, people like us, to give an opinion about an esophageal cancer with that stage. I don't think it's not fair. I think we need the opinion about our colleagues who have the specialization in esophageal cancer. And after, if they agree to do the operation in esophageal, after, okay.
Apparently, I can say apparently.
A technical problem of to resect or not to resect liver metastasis, please. It's different. This kind of tumor of esophageal have surgical indication? I don't know, but I think they have no indication at all.
The patient was referred by, in fact, a gastroenterologist to me, okay? And he said there is no more tumor in the esophagus. So difficult to convince my colleague, upper GI surgeon, to resect this patient knowing that there is no more tumor. And the only tumor still detectable is the tumor in the liver. So this was his, I would say, strategy in referring the patient to me. So, but what would you do? If you have an opinion of the upper GI surgeon who said, for us, no indication presently to do any esophageal surgery, what do you do?
Guido.
We have...
Okay, I don't know.
You don't know.
I don't know.
You don't know. Okay, no.
Guido.
In our
it was as we are that day. We don't know what to do.
If the esophageal surgeon say there is no indication for surgery for the esophagus, and if he send the patient to you for the liver metastasis, I think that you consider the liver metastasis with a good result of the primary. At that time, personally, I will treat the liver metastasis as usually we treat the liver metastasis. That means in this case, I will do resection.
Okay.
Guido.
Another opinion, Laurence?
No, Guido first.
Guido, sorry.
Sorry, Laurence. Guido is...
Sorry, I'm waiting since the... no, but it's not, I'm not doing the boss of, but I was waiting my time. I would like just to say that in our institution, our department have several units, and there is the unit of the upper GI. And I must say with surprise that nowadays this is not heretical to operate liver metastasis. They ask us. We have done simultaneous resection when there are simple disease, or even a tunnel in a case after a good response, after the primary removal, they still proceed with the chemo. It was stable, single lesion, we did a tunnel hepatectomy. And the results are not that bad. I mean, the biological better knowledge and the systemic treatment are changed, of course, have changed the approach. And nowadays is really not heretical at the point also of the upper GI surgeon to offer, they were demanding. In this case, I have never had up to now a situation in which the primary disappeared, but I may say that if we transferred some, given the results of the chemo, transfer the experience of the colorectal, even if it is a different disease, but we have to mutuate the expertise we had for the liver meds and the expertise of the upper GI surgeon that recommends surgery, it could be not crazy to move to the clearance of the liver. I don't know.
Laurence and then Oscar.
In fact, I agree with Eduardo. It's not a surgical problem, it's an oncological problem. So the point is if we have a esophageal surgery in our department, and the point is when the tumor is disappearing after modern chemotherapy, they do not operate on epidermoid cancer, but on adenocarcinoma. They operate anyway even if there is no sign of tumor. So the point is, your surgeon, your thoracic surgeon said, no need because there is metastasis, or no need because he doesn't want to, he said that the tumor disappeared.
And not the contact with the esophageal surgeon.
Of course, so they do the surgery. So logically, both had to be done if you want to, because the difference, you know, that we did this report, and this case is very bad prognosis, but it was before modern chemotherapy, of course.
So, yes,
René,
Oscar.
are you still using the score that you developed several years ago in non-colorectal,
yes,
non-neuroendocrine tumors? Because if I remember well, it should be 2 or 3 points in this case.
I come to that. So I don't know why it doesn't move. So a big debate in our tumor board meeting, really, when I present this case. And I should say, very frankly, the majority said, if we do resection, we are a little bit crazy, okay? And the things are, when we did with Laurence Chiche, the survey in all the French cases were non-colorectal, non-neuroendocrine tumor, we come to only 8 cases of among the 1,400. Okay, so a minority with very mixed, I would say, outcome, very limited experience, disappointing result, and so we come to the conclusion with Laurence that there was, for metastasis from esophageal cancer, no indication for liver surgery. Okay, and so when we did the prognostic, I would say, evaluation in the French survey, in the French cohort, of all the factors involved, in a way to applicate on a case-by-case this prognostic model, we come to the conclusion that this patient needs a major hepatectomy. He was more than 60 years old. He has a time interval less than 12 months between the primary and, of course, the metastasis. And he has no another cancers than breast, squamous, or melanoma. And so altogether, we come to the evaluation that this patient was in the, I would say, relatively intermediate risk with a 5-year survival expectancy of 33% at 5 years, okay? Another point is that, and this has been done on the initiative of Christophe Mariette, an upper GI, I would say, surgeon who passed away, unfortunately. And you can see here the experience in French centers, 17, about what may ablation or resection add to chemotherapy alone. The interesting point was this was a case match study. So apparently comparable patient, not, of course, because chemotherapy patients are different from that of surgery. This was a case match group, and it comes to the conclusion that apparently to combine resection or RFA with chemo was associated with a better survival. And also what we did with Angelica Lucchese from Porto Alegre and an alumnum of Antonio Kalil, in the liver-met survey experience, we show that the response to chemotherapy, whichever is a non-colorectal, non-endocrine liver metastasis, it is a major factor of long-term survival. And so with all these arguments, we decided finally to reconsider surgery. And at the multidisciplinary board, why not to attempt surgery? The point is which hepatectomy do we perform for this patient? Because it's not an oligometastatic disease. It is really a very extensive hepatectomy. And so I give you all the elements. We need to make a right hepatectomy extended to segment 4 with a partial resection of the left lobe. And here you have the evaluation. A ratio, future liver remnant on the body weight, of 0.5. it is the accepted limit to do the hepatectomy. I advance because if not, we will take too much time. We decided for lowering the risk to do anyway a portal embolization. In a way not to be faced with a problem of liver insufficiency. We gain with portal embolization on the left remnant liver, and the patient was operated 5 weeks after PVA. We find no extrahepatic deposit, confirmation of the same liver mets, right hepatectomy enlarged as it was planned initially, uneventful by chance post-operative course, and controlled CT scan, small collection anyway, no significant complication in this patient, and that pathology. This is very important, of course. Complete pathological response of the 4 metastases that we have remained, we have resected, also in the right as well as in the left part of the liver. And there were also 6 lymph nodes without any tumor. Good, so we are happy. And the patients also, and the gastroenterologist also. What to do now for the primary?
Send the patient to the oncologist because we will not ask about that.
Okay. So,
you remember my father. My father was a doctor. And he didn't like surgeons, He told me he was very disappointed. Because he said to me 40 years ago, Eduardo, I prescribe aspirin, I prescribe antibiotics, I prescribe surgery. And I remember my father now. With this case, I think this is an anecdotal case, of course. Perhaps we have done right, but okay, that's all. That's because we are prescribed and they are done to treat that patient. Now send the patient for the oncologist.
I did so. And we planned for this patient adjuvant chemotherapy, which was so active before. We expect that it will be also active after. 5-FU cisplatin and Herceptin, because we have to have in mind this patient was HER positive. This is a good prognostic factor. Upper endoscopy with esophageal biopsies, no tumoral cell. And May, June 2020, we decided with the oncologist, he called me and so on, we do radiotherapy in a way to, I would say, to confirm the pathological complete response apparently observed in the esophagus. Okay, we did so. And this is the evolution at 3 years from diagnosis, 2 years from hepatectomy, asymptomatic, normal CEA, new endoscopy, stigmat of radiotherapy, no esophageal recurrence, and no recurrence in the CT scan. So it's good, huh? It's a good end, but it is not the end.
No, it's not the end.
Because at 2.5 years from hepatectomy, despite the fact that multiple biopsies have been done in the esophagus and so on, a new control endoscopy saw a resurgence of the initial tumor extended on 20 millimeter. T1 and 0 on echo endoscopy. At that time, the esophageal surgeon said, we plan to do esophagectomy with lymphadenectomy, but Lewis-Stanti with a double approach, thoracic and abdominal. By chance, uneventful postoperative course. At pathology, it was not T1 and 0, it was T3 and 0. No postoperative chemotherapy was done at that time. And this is the last status. It's a very good shape. Control endoscopy normal, tumor markers normal, CT scan normal. And so, to summarize this case, double esophageal adenocarcinoma with synchronous bilobar metastasis, but excellent response to chemo, who made that we rediscuss surgery, doing a relatively extensive hepatectomy, with a complete pathological response, not only on the esophagus, but also on the liver, which make us propose initially a conservative approach on the esophagus, but at 3.2 years, there was a recurrence, a resurgence, in fact, of the initial esophageal cancer, who make that we come to esophagectomy. But this patient presently, it's alive disease-free, 4 years from diagnosis, 3.5 years from hepatectomy, and 1.2 years from esophagectomy. And I have another patient like this with a much shorter follow-up. He is presently at 2.5 years of the same approach, liver first approach, and then esophagectomy by combined approach, sequential, but we begin by the liver, and he is presently at 2.5 years from the diagnosis, alive, disease-free, and each year he sends me a photo of him because he's doing, I would say, the way of the Santiago de Compostela, and he sends me every time a photography saying, thanks to you, I'm still alive. So, no, it's just for saying you that, of course, if we want some time, 1, 2, 3 cases are sufficient to change our strategy, to change our attitude. And I will have a different look now when an oncologist, a gastroenterologist, will propose me to operate a patient with liver metastasis from esophageal cancer, provided, of course, that this patient responded very well to chemo, and that the liver surgery is not very, very risky. So this, in my view, is the message. We should be, I would say, in acceptance of such type of things, of patients that change the way we are treating the patients.
One question, René. Would you consider, for the message for the upper GI surgeon, I mean, is it an approach to say that as long as you respond to the chemotherapy, there's no need to operate? Because at the end of the day, that's what the problem was.
You know, I cannot speak at the place of esophageal upper GI surgeon or even colorectal surgeon. It's the same debate for esophagus, for colorectal. When a tumor has totally disappeared while on a very efficient chemotherapy, should we resect, not resect? It seems to me that colorectal surgeon now, especially for rectal cancer, the attitude of wait and see is the preferable approach. But for the liver, for all our area of, I would say, surgery, I would say, I don't advise to wait and see, but to go every time to surgery, because the metastasis, the initial metastatic site, in the vast majority of cases, still are tumoral.
I have a question.
Yeah.
Hi, thank you. Professor, great case. I just want to ask you a question. Earlier in your case, I was surprised that you didn't remove the lesions in the left before embolizing the right portal vein. So you picked portal vein embolization instead of 2-stage, and we usually remove them before. And that also would have gave you information regarding the pathological response to further justify an aggressive treatment. Why you didn't remove the lesions in the left? Thank you.
Thank you. It's a very good question, and usually the principle is not to let in place a tumor when we embolize the contralateral liver. I fully agree with you. The only point that led us not to do it is because if not, we will go into a sort of 2-stage hepatectomy or radiofrequency. It will still have complicated the things, and from the time that it have been a very fantastic reduction in size, we hypothesized at that time that the risk of hypertrophy of such type of tumor will be probably lower than a usual patient not responding so well to chemo. But it's a very good point, very good point.
Guido.
Just, we had, because my age, I had to review the abstract of the paper that we published on this argument on cancers. And we did a review of the literature according to the fact that with the upper GI surgeon, which stimulate us to do the surgery, and there are 20 papers talking about liver oligometastatic disease from esophageal cancer, and below 3, so you are just up in the other, but 3. The survival at 5 years reported in that paper is between 30 to 50%.
It is, sorry?
30 to 50%. More than 3, it is around 10% at 5 years, despite the chemo successes. So I think that in this field there is a wide room of improving our role, and I may say that personally I would have done a parenchyma sparing anyway.
Sorry.
Professor Bismuth. Rodolfo.
René,
Rodolfo.
very good case. So I have the same question as Fernando, but another thing that is important to take in mind is that the esophagus have no adventitia. And that is one thing that at the moment to decide which organ go first, it's important to take in account because the dissemination through the esophagus is quickly from the other digestive tube that have serosa. That's important thing that always the esophagus surgeon say.
Professor Bismuth.
René, I ask you a question. If we have to take a message, we have two organs with cancer with a link between them. Surgeon, two specialist surgeons. So the question is, what is the message in this case? I think personally the liver surgeon did very well. For the esophagus surgeon, there is a question. Do we think that with adenocarcinoma of the esophagus, treated only by chemotherapy, there is a chance of cure? This is the question. If the question is yes, it was what you did, both. If the question is not sure, at that time, the question is, he may have do the surgery before sending to you, or first, according to the program of Gilles to cure when there is metastasis coming from an organ, to cure the one which is more symptomatic, and in this case, the tumor disappeared. The only tumor remaining was in the liver. So it was a justification of doing first the liver. But
Yes.
if the cancer, the risk of recurrence of the cancer was high, at that time, he has to do esophageal surgery or before sending to you or after you cure it. So what is the message if we analyze?
First, is chemotherapy able to cure patients? The response is no.
Kind of.
No, because
Not squamous, it's adenocarcinoma.
Adenocarcinoma, usually no. And this patient is a good example. He has a complete pathological response. And nevertheless, he recurs in the esophagus, and he will have recur possibly in the liver if we have not removed it. This is an hypothesis. So can chemotherapy cure a patient with adenocarcinoma of the esophagus? The response is no, or exceptional, we will say. And in view of the attitude to do the primary first, the liver first, and so on, there is, of course, a big debate. But I think when you have no tumor at all, confirmed by biopsy in the primary, and you have still big tumor in another metastatic site, it is not so unrational to begin by the metastatic site. And I don't know if Felice Giuliante has done a very important work in LiverMed survey, showing that in such type of patient with bilateral disease, the liver first approach for colorectal, not for this patient, for colorectal, give the significantly much better survival than combining the two approach or doing the colon first.
If you look at this, the only error was in the point where conservative approach to esophagus. This is the mistake. The esophageal surgeon might have do here, but perform here, surgery of the esophagus. All the rest is correct, except this point.
It's difficult to accept the rationale to be aggressive in the liver and not to be aggressive in the esophagus. So this is for me the most difficult to understand, but I agree. Perhaps the message, final message is very important. For now, every cancer of the esophagus with liver metastasis who answer to the chemotherapy must be operated. This is the problem. Because I'm sure that the rationale is very difficult to accept. Very radical
Why?
in the liver and not radical in the esophagus.
Yes, but each case is different. For example, the other patient I am speaking to you has had a Lewis-Santi operation, but the liver first was done. Liver first, because the tumor in the liver was very big, and he has not a complete response, but a good response on the esophagus. And we plan together to do the liver first, to do chemo in between, and then to do the Lewis-Santi procedure. But so to do the Lewis-Santi in this patient because of the complete response. It was a complete response with biopsy and so on. So the upper GI surgeon said, we wait and we see, and if recurrence, we operate. It's not, for me, something crazy. With the history, we say that the patient has had a recurrence. So we can say today, it has been a mistake not to do. But possibly this patient exceptionally could have had a complete response, definitive on the esophagus. It's not so frequent, but this patient is not so frequent. Now, what my message for all the young surgeons and even the less young in the audience is that if we want to do any progress, we have to be disruptive. And sometimes, because the facility in such type of patient is no, because the recommendation, meaning recommendation 50 years ago, and all the past has said no indication for surgery. So we miss in some patients, very exceptional one, of course, the possibility. And now this may change my view, and I don't know yours, but my view, because when a patient responds very strongly to chemo, I think we can change the dogma of saying no, which is a facility.
I agree with René, and when I presented the case of pancreatic cancer with liver metastasis in Ireland, Eduardo had the same comportament. But when I met him in the airport, when I arrived in Milan, he asked me the first question, what about your patient with pancreatic cancer and liver metastasis? And I said, he is well. 7 years later, I have a video for you. So,
when I presented our cases, liver transplantation in liver metastasis in Buenos Aires, how many years ago?
São Paulo.
Eduardo told me, they said, if you are in Argentina, I was arrested. If I was in France, I was arrested. If I was in England, I was arrested. So I agree that we need to be open for the news. And I don't say that if you are in Portugal, you are arrested to do that. No, you are. This is a good case, but it's an anecdotal case. That must be presented as an anecdotal case, not as a law. That's because I am a little bit I am outside of surgery. I don't operate anymore.
Lee, then Laurence and Rashad.
Excellent work, René. Congratulations. You mentioned that there was a complete pathological response from the tumor. How did that correlate with the PET scan? And the reason I'm asking PET scan is a very useful investigation, but how well we can rely on it.
There was no uptake in the PET-CT when the patient
show
has
activity, for example.
no activity. But we know, the PET-CT make an uptake when you have a tumor at least of 1 centimeter. So you may have tumor even with a PET-CT negative. So the PET-CT is indicative of the response, but not really about the pathology. No imaging technique is able today to say this patient has a pathological complete response. Radiological, yes. Pathological, no.
Lohan, sorry,
Yes,
Lee
just
first. No?
Neither in the liver specimen nor the esophageal specimen were any of the lymph nodes positive. So there's biologically something interesting about the way this tumor is metastasizing, spreading, and it never was seen in the chest. So it's a biologically interesting tumor.
Absolutely. Sometimes the complete pathological response also concerns the lymph node. What I have not seen in detail is the specimen of the esophagus. because this patient has been operated by a private institution, and I have some difficulty to recuperate all the operative, I would say, and the pathological findings. But apparently it was, as I said, PT3.
Laurence?
0.
Just a comment about the conservative approach. In fact, this liver first strategy has been described first for rectal cancer because rectal surgery can be very morbid. And I have to say that the Lewis Santé is a very heavy procedure with, well, it went well here, but there is a lot of morbidity, and particularly nutritional denutrition, etc. So I think that what change, you said what change is chemotherapy, of course, but also the risk of surgery. And I think that it's when you do this type of hepatectomy, the risk, and particularly for prepare or do a conservative approach, the risk is very low. So you have to take into account the risk of both surgery. And I understand that you did a radiotherapy because this type of surgery on the esophagus is not even now a simple procedure for the patient.
Important point in my view, very important point.
Joe.
I just want to say something more philosophical than anything, because if you remember, what was it, Adson did the 60 biopsies and then 60 resections back in the day with the liver metastasis, and something I tell the residents every day, and you are the epitome of it, Mr. Bismuth, if you do everything you're taught, you will never learn anything. I'll leave you with that.
Agree.
I am the last to speak. If I am the last to speak, I would like to say that. We are treating individual, not a group. For instance, if for a cancer, a disease, there is only 1% of survival, people will say, oh, no indication for surgery. But another answer, who is the one? And we have to look for the one. This is our duty. Duty is to try to find the one and to treat the one.
Artificial intelligence will help us, and molecular biology will help us to know what is the one, or the two, or the three.
This one. And I think we have to do that.
Thank you.
Okay.
I think excellent talk, and I agree the one matters more than the 10. We took the liberty to have time when we have session that might change our practice. I don't know if and when Catherine is coming. In the meantime, as she's not here, we'll call Juan Picolch from Argentina.
Okay, thank you. Good morning. First of all, thank you for allowing me to be part of this tremendous group. This was the last visit of Dr. Bismuth to Argentina, 2017, that this is our group. And something is important, this is a friend, Miguel Ciardula, that all you remember, and we are here like fellows through him. So my recognition. Also, Dr. Bismuth was in Argentina giving good lectures, and we put him in a quite challenge that they have to give us the best lecture that he have, and was a tremendous success in Academy of Surgery that more than 2,000 people was hearing him. Also, I want to thank Dr. Guido Torsili. We were together in Lisboa, but the interesting thing happened in Lisboa, and I saw this one. You can see here that Dr. Bismuth is saying something to Guido, and he's saying, Guido, think about a Compagnons meeting here in Milan. So here we are. Okay, I put some non-formal name to my lecture because it was one of the things that asked me Hugo, and I said, so probably this is a big surgery for a small lesion. However, with all the previous cases that we have, I feel really more comfortable than what I did. So this is a female, 56 years old, 81 kilos, BMI 29, no previous diseases. In November 2020, have a recurrent abdominal pain in right upper quadrant. Lab test was okay, except phosphatase alkaline was double, and the markers were normal. She had an ultrasound outside of our hospital talking about some cystic dilatation of right hepatic duct. So we did a CT scan. In the CT scan, we can see a kind of cyst related to the right pedicle, also in the different position of the study. So we ordered at this moment a cholangio MRI. In cholangio MRI, you can see perfectly the dilatation in the right side of the biliary tree. And also it's interesting to see a variation of one vein that is inferior right hepatic vein. We'll see why I'm asking or talking about that. In the reconstruction of the cholangio MRI, you can see perfectly the dilatation here in the branch of the right side, but also the anterior and the posterior have some dilatation. The rest of the biliary tract looks to be okay. There are no maljunction. Here is the reconstruction, and was the diagnosis of our radiologist is not a cystic dilatation like a cyst in the Todani 5, but probably is 1 IPM of biliary tree. So looking for the classification for intrahepatic IPN-B, you can see there are different modes, and probably the type 4 could be related to this one because it's dilatation of the ducts and some cystic lesion. We were talking today about the spice glass. We did the spice glass. The spice glass have seen some irregular and edematous mucosa in the right hepatic duct. They have seen some neovascularization. Also, they did some biopsy in the area with the small spoon that they have. However, this was negative for atypical lesion, so for to say there is a carcinoma. So we were sure there is an IPN, so we have to do a radical treatment or the logical treatment. So the logical treatment is right hepatectomy. But we have a problem. When we were looking at the volumes, we can see the left liver was quite small, 22% of all the liver and 0.4 the relation between the future liver remnant and the body weight. So there was no doubt that probably we have to confirm, and we did the nuclear medicine study, and we have seen there is 19 SPECT and 41 of EVA index. So we say it's not enough left liver. So we decide that this liver have to grow, and in this moment we prefer to order directly a liver venous deprivation that will have as much better the regeneration. And in this moment it was important to remember this vein because it's an accessory vein, so when they did embolization, they have to do of the right portal vein, of the main trunk of hepatic vein, and also of this accessory. And really the result was amazing. You can see how grow the left liver. You can see here the data, how changed completely from 29, 22, past to 50%. And EVA index, you will see later, but 0.7 was a good number, still a little lower than I expect. However, when we did the nuclear medicine, we have seen the SPECT was 58, and the EVA index is 31. So we said there are no doubt that was a good idea to do the portal liver deprivation. So we decided to do bilaparoscopic approach, just some technical aspect of the surgery. We mobilize the liver, we translate the round ligament, the falciform ligament. I'm not staying among the legs, but from the left side, we prepare for a Pringle maneuver. There are many ways to do the Pringle maneuver. I prefer this one. This is an extracorporeal and very cheap because just used a plastic tube for the chest, and you can clamp anytime that you want outside, so it's very easy. Here is prepared for the Pringle maneuver, the tourniquet. We have to confirm the lesion, so there are no doubt that we have to do a cholangiogram during the surgery. We did a transcystic cholangiogram. You can see perfectly how is the dilatation of the right duct. The junction is okay, the left is okay, so the next step is to identify the right hepatic artery. In this case, it was retrobiliary hepatic artery. With blunt dissection, we identify the right branch. We put a clamp, just to confirm that everything is okay. And this patient, you can see how good is the demarcation because have a previous embolization. We continue with some part of the mobilization of the right lobe, especially in the upper side of the right liver, mobilizing from the diaphragm. And when we complete this one, we went to put clips and transect the right hepatic artery. We remove the bulldog clamp, and we use routinely hemolocks. The next step is to go to the portal vein. We never use in the trunk of the portal vein any kind of plaques important, so it's easy to handle during laparoscopic surgery. We identify the right branch of the portal vein, again with blunt dissection. If it's small, we can put clips. If it's bigger, we prefer to put a stapler. A tip is nice to leave a part of this tissue that is easy to handle the portal vein. We put a vessel loop to complete the dissection, and that we are sure they are far from the trunk of the portal vein, that we are not compromising the left hepatic branch of the portal vein. Again, in this case, it was small. We put hemolocks. Completed the transection of the portal vein. Now we have to start with the biliary time. In a different kind of right hepatectomy, we resolve the duct inside of the parenchyma. Here we have to do outside of the liver the dissection, close to the carrefour. So we mobilizing the anterior and the posterior face of the bile duct. I put a clamp on the cystic lesion to know we have enough margin. And we perform again another intraoperative cholangiogram. We have seen that here we have still some place for to cut and to suture. We're not going to resect the left duct and the common junction. I'm leaving some millimeters of the lesion that I'm able to suture, and they are not stricture of the carrefour of the biliary tree. We perform intracorporeal stitches one by one, and when it's completed the suture, I perform again another cholangiogram to ensure that everything is okay with the left duct. Now we're going to start with the transection line. I progress a little. We use different instruments. One important thing in the right hepatic resection is not to work in the anterior phase of the vena cava, but paracaval, so you are avoiding to have a problem with the carotid lobe. We are starting here the transection of the right liver. In this case, we're going to do a hanging maneuver, but the hanging maneuver is also not in the anterior phase, but is paracaval, and it's enough to mobilize the liver for the right and to the left. Remember that here we have a big left liver, and it's making difficult the mobilization of the specimen. Also, the hanging maneuver later is going to help me to find the right hepatic vein. We use different devices, ultrasound, we use ultracision, also we use CUSA, depending if we are deep or we are very superficial. Here is the last part, when is the right hepatic vein, we use directly a stapler. We remove the specimen through the fan steel incision. We sent to frozen section to check the section of the biliary tree. There is no disease. We complete the coagulation using argon beam coagulator. In this case, we have to use permanently the suction device that you don't have abdominal hypertension. And you can see here the specimen. Next, please. No. Next slide. No. Could we give me the next slide, please? Okay, thank you. The operative time was 210 minutes, no blood transfusion, only one Pringer maneuver at the end of the transection of the liver. 1 day in intensive care unit, 4 days in the hospital, and day 11, the patient have fever. We have seen they have a fluid collection. We put a percutaneous drain for 3 days and was resolved. When we go to the specimen study, you can see the diagnosis was intraductal papillary neoplasm, as we suspect, with mild dysplasia and with tumor-free margin. So for us, in this moment, was enough the surgery that we performed. Here you can see the dilatation and the appearance of one of the criteria that is necessary to have to show that there is papillas in the mucosa. The patient is more than 2 years after surgery and she's doing well. We have to remember that nobody knows how long we have to follow the patient, because this is not a problem of a section of the mucosa, but it's like in IPMN in the pancreatic, we have to follow because it's a problem of all the ducts. But at this moment, this was okay. And again, I think there was a small lesion. I did a big surgery, but was the necessary because we have many examples today that we have seen a very advanced disease, and I have a very early disease, but the solution was a right hepatectomy. Thank you very much.
Case open for discussion, but it was interesting to notice that today was the day of the IPNB. Huh? Everybody has IPNB today.
After the COVID, the next pandemic is IPN.
IPN.
The most common lesion in the liver.
Any comment or question? Yes. Okay. And then Ugo.
Thank you for a good presentation. My concern is you performed the laparoscopic surgery, very excellent, but you opened the bile duct. I mean, the bile duct juice is into the intraperitoneal cavity. For when the treating IPNB, is it the risk of tumor dissemination? How do you think that?
Yeah, it's a good thing. I know that in open surgery it happened the same, except we put a clamp, but there are no doubt that we have some, also doing cholangiogram, you have some drops of the bile. An advantage that we have that this was finally a dysplasia, mild dysplasia, and probably they are not going to have problem. But it's still the same problem when we are operating Klatskin tumor. We are operating Klatskin tumor, they are adenocarcinoma, and we are opening the bile duct, and we have spillage during the surgery of the bile. However, the recurrences in the peritoneum are so rare.
Thank you.
Yeah, thank you for you.
So one very nice operation. Just to tell you, you did frozen section of the bile duct when you removed when you cut that point.
When I removed the specimen through the fenesty, I sent the specimen to the pathologist because I have to take the same decision that we're doing in pancreas. In pancreas, you are transecting, for example, a Whipple, and I send to know if there is mild dysplasia, it's okay. However, you have advanced dysplasia or intraductal carcinoma, you have to complete the resection. In this case, I have to resect the left duct and the carrefour and the extra hepatic ducts.
Exactly, that was my question, if you consider doing this from the start.
Yes. My concern was the junction. If I have enough, you can see in the video that I am leaving 2 millimeters of dilated duct, but it's the way that I can avoid to injury the confluence of the ducts. For the reason, the diagnosis of the frozen section was very important. Yeah, thank you.
Do you have a protocol follow-up for these patients?
The follow-up is like waiting for some stenosis. The tumor markers were normal in this patient, so we use like in all oncologic patient, first year each 3 months, second year each 6 months, third year once a year. But the patient know that they have to be followed. Also because it's young patient, younger than me, 50, 51, 52, so this is the problem. Completely different if you are doing a surgery in an 80 years old patient. It's like in pancreas, you change the decisions, no?
Laurence?
Thank you for this beautiful liver deprivation. I like that. The second is all this discussion, as Jina said, it is the day of IPNB. And it exactly like the debate about IPNM of the pancreas. We don't know exactly what type of lesion we had to operate and when. And probably there is a problem of size, like IPNB, of main duct, or so we don't know, and we don't know how to follow this patient, probably by our MRI, but we don't know. So we have to collect these cases in order to understand the disease, and which is quite new, in fact.
Yes.
Because it's fascinating for everybody, and to try to determine the right indications and the timing of a big operation for a small tumor, because I have one exactly the same, and I follow because it was difficult to decide a big operation for a small lesion like that. I agree, but you did it so well in the laparoscopy.
I think that the age of the patient is very important.
Yeah, I agree.
This patient also have a special history because she had the symptoms in November 2020. And I spent more than 1 year to operate, and I did the studies before. But she get divorced, have a big problems in the life, and said, I'm going to operate later. But they have again abdominal pain and say, you are doing pain for the lesion. Please, let's go to surgery.
You sure it's for the lesion or for the divorce?
No, because she had the same pain previously.
I'm really happy, basically, for all these cases, and I agree with Laurence. I mean, it's something that we should consider, but it is important to start to collect these cases, sort of having a large database, because we need that. And as René knows, artificial intelligence is coming if we want to depict the one, so we have to have the habit to do these databases. Excellent, and thank you very much.
Dimitri.
Just a quick additional comment. I think with the introduction of laparoscopy and robotics, I think your title may be a little bit of a misnomer, because it's a big surgery volume-wise what you remove, but is it a big surgery on a patient anymore? Because when we do these things minimally invasively through fan and steel incision, 4 or 5 little incisions, it becomes very similar to cholecystectomy in terms of the impact on the patient and their recovery. They stay, some of these patients can be discharged the following day or day after. So it's not necessarily the same magnitude as an open operation anymore. It's just.
Yeah, I think the advantage to do these procedures through the mini-invasive access is wonderful for the patient, there are no doubt. And also the specimen that I removed was a surprise for me because in the first CT scan, the right liver was 1200 cc's. That I removed was 390. So it was this piece with 3 hours and a half working, but for the patient was to resolve the problem, no? So I agree that. Thank you.
Thank you.
Thank you.
Juan. Let's move to the next presentation by Rashad El-Masri from Egypt.
I'd like to thank Professor Bismuth, Guido, Hugo for all their effort and thank for accepting. It's a 70-year-old female who came to us some 8 months ago, bad historian, but at least 6 months of history of abdominal pain, vague dyspepsia, and possibly weight loss. General examination was normal, that she's not cachectic, but she was thin. And there was a mass in the right iliac fossa, which is soft, slippery, and you can get above it. The only thing in the investigation, the sedimentation rate was 80, but all the hematological, biochemical, viral, and tumor marker were normal. And ultrasound showed that she's got an average-sized liver and distended gallbladder, quite distended, multiple gallstones, and a fungating mass at the neck. This is the picture of the CT, which you could see there is dilatation of the gallbladder. At the gallbladder, and you can see here in the area of the neck here, there was this mass here, and obviously the gallstones. Report of the triphasic CT showed the distended gallbladder and the polyp, possibly polyp, with the dilatation of the hepatic ducts and intrahepatic bile duct. We did a complementary ultrasound and Doppler. We showed that there was an internal vascularity in this mass, but otherwise normal vasculature. And they queried whether this is Emerysi syndrome. So the next thing was to do, is to do an MRCP, which confirmed this dilatation of the bile duct themselves. And looking at the sections, there is a constant filling defect here. They couldn't be sure whether there's a tumor, a polyp, or fixed stones. So they suggested to do an ERCP. We weren't completely agreeable, but we asked the gastroenterologist. They mentioned that the biochemically was completely normal. There was no point of doing any invasive procedure. Discussed it at the MDT, and we said we proceed to the PET scan. And the PET scan was normal. There wasn't any activity apart from this area, which coincided with the soft tissue mass at the neck. It was a distended gallbladder, general wall thickness, and SUV max uptake was 3.5, and mild to moderate bile dilatation, and no other lesions. And we discussed it with the radiologist, and they said for them, the cutoff level is 5 FU max to be sure that there is a tumor, but otherwise you can rule it out, and it could be an inflammation. And this is the summary of the case, and that's what we found. So what do you think the management would like to be? What would you do in this particular case?
Comments?
Tumor marker normal. Alpha fetoprotein, CAA, CA 19.9, all normal. CRP normal, liver function test normal. There wasn't any rise in the liver or biliary enzymes at all. And the bilirubin is normal.
Let's go for cholecystectomy. Let's go for cholecystectomy or not?
Radical cholecystectomy or a simple cholecystectomy? Okay.
Large. Who's in favor of surgery?
Any more investigation, or shall we proceed with surgery, and which type of surgery will do it? Open or laparoscopic? She's 70 years old.
No, no.
Right. Shall we proceed? Any comment before I continue?
Go ahead.
Okay. So we agreed to go for surgery. Encouraged by the point that is possibly 3.5, it's not a tumor, we proceeded with laparoscopy. There was no alarming signs at all that it's a tumor, a mucocele that we aspirated, adhesiolysis. It was for the mass, it was a thick wall, very thick linings. It wasn't easy. The artery came first and we clipped it. As you can see it here, this is the duct.
Just for a joke.
Yeah.
Are you thinking to take out the gallbladder or to put the gallbladder inside the abdomen?
Leave it in the abdomen, maybe. You see, well, each case is particular anyway. But he's done very, very well many years ago. Right. The cystic artery came first and it was clipped. This is the cystic duct, the common bile duct. Triangle of safety. We're about to clip the duct now. We proceeded very slowly. It was a difficult, adherent. Everything moved all right. You can see here, this is the cystic lymph node. This is probably the mass here. We weren't quite sure at the laparoscopy whether it was a mass or a fleshy tumor. We proceeded until we got very nearly to the end. The plane was difficult. We started to bleed. We couldn't control it properly, and it was the correct time to convert it to open. As we converted to open, there was this fleshy mass here at the fleshy but firm at the fundus, the gallbladder. Most of it was removed by laparoscopy, but was this area which was adherent to the liver. We didn't know what it was exactly. We didn't like to do a frozen section, so we decided we were going to do a limited liver resection. By the way, when we did the open laparoscopy, we felt the whole abdomen. There wasn't any enlarged lymph nodes, and we felt perhaps it was enough to proceed with the case. This is the surgical specimen, as we said. This is the mass in the, at the neck of the gallbladder. The gallbladder, as you can see, it enlarged and thick, the liver resection. And this is the open section of the tumor, markedly thickened gallbladder wall. This is angry-looking mucosa, and this is the local thickening. Any guess what this pathology could be? This area of the mucosa, which was very suspicious. I was with your opinion, actually. Anyway. This is the pathology of the gallbladder, the body itself, the area where you see it very angry. It was only inflammation, very angry and velvety. They examined the liver, which was completely normal, no evidence of tumor. And this is the pathology of the mass and the gallbladder itself. It was showed an adenocarcinoma. So the final pathology, it was a well-differentiated adenocarcinoma, inferring the thickness, but no involvement, and both cystic duct and liver resection was free. So the lesion was T2 and 0R0. It's nearly, yes. And zero, that was just this cystic lymph node. Only one lymph node. Whether you would like more, we cannot comment on it. But we had a feeling there wasn't any enlarged lymph nodes. She's 70, and she proceeded, and we were gonna, I mean, classically it would have been removing the nodes and maybe the extra biliary tree, but it was a very big procedure for her at their age, and I had no definite histological confirmation. That was the situation, so that's why I did it. Yes,
from my recollection, the T2 lesions, even N0, M0, and what Pietro's getting to, there's probably not enough nodes. Just based on the T2, you should have a segment 4B5 resection, because those are the patients in all the literature that are going to have the best long-term results with the T2, you know, N0, MX, whatever. That's the one that you're going to really salvage.
At the time, we did not have the histology. That was the tumor was not.
You have to go back.
Regularly, and I think everybody receives this kind of patients with the pathologist finding the tumor on the specimen and addressing the patient to you for surgery. And you have to do surgery doing exactly what Joe says within 4 weeks. This is what we do.
I agree. This is a consensus.
Yes,
because
I mean,
the operation is not complete.
Discussed it at MDT, and it shows, and I say that for the time being, she's follow up closely, and that's the point.
It's not follow. It's within 4 weeks.
No, we've passed it. Okay. Anyway, so she's been seen at 3 months, and then she was completely normal. But we'll follow her up, and I think you could. Do we go again now and do more liver resection if it's not showing anything now, or should we just follow up? I know it's not.
Oscar?
Everybody's agrees that perhaps a radical cholecystectomy should be complete, but at 3 months after surgery, do you think it's worth it to do that? Do you have a cutoff to take the patient to a radical resection, or does it not matter the time between the surgery and the radical resection?
I would do it nonetheless.
Because usually we say 1 month, 40 days.
But there is one of my favorite saying from my psychiatrist that wrote beautiful books is, give up the hope for a better past. And this is exactly the case in which you have to give up the hope for a better past and go for the surgery. Maybe the cells have remained in the lymph nodes that you will resect. So I would certainly discuss it, of course, with the patient, but we would do it even if the patient is addressed to you 3 months later.
And don't forget, the studies that were done were before people came up with the 4-week idea to go back and do radical resection. Those T2, I repeat, those T2 lesions are the ones that are most salvageable and probably have the best overall survival in terms of, and I don't think the timing is relevant in terms of being perfect because there's usually these patients, you know, at least when we got to see them, was well after 4 weeks and many times. It wasn't that they were rushed to the hepatobiliary surgeon. So I think they should still do, you know, 4B5.
She's 5 months and she's coming next month. So do we offer her, you mean this segmentectomy after this all the time?
One last thing, this idea of radical cholecystectomy, when you talk to American surgeons, for the most part, what they call radical cholecystectomy is taking out the hepatic plate. This is not the operation, and that's a wasted operation. You need to do what Mr. Bismuth has described many, many years ago, 4B5. You need to re-examine the cystic duct frozen section, and you need to take all the lymph nodes from the bile duct to the pancreas. And when I've done this operation, I even go retroperitoneal to the paraortic space.
I have some concern about one maneuver that was performed by laparoscopy, and it's the puncture evacuation of the gallbladder. We know that we are operating gallbladder cancer, though in South America, also now we are starting to treat with the liver resection, all these things. The bad results that we have with implantation in the trocars was patients that we operate with the diagnosis of acute cholecystitis, and we did in the gallbladder what we don't have to do in a cancer, with punction, with traction. So if you are thinking to offer the patient the segmentectomy, I will recommend to start with a laparoscopy, just to check if you don't have seedings in the diaphragm.
Yeah. But as a general rule, I agree with Juan, because I have the impression that from the beginning you knew that it wasn't going to be something benign, as the polyp or the lesion was big enough. It was more than 2.5 or 3 centimeters.
That's the point, yeah.
So at that time you say, I have to operate, it's a radical operation. And I agree with Pietro, within 4 weeks, if you have the results of the histology, you have to go back and do a proper lymphadenectomy and segment 4B5 resection for the type T2. It's very important.
Well, the point is that the PET scan was low and you didn't have the confirmation, and the elderly patient. And we discussed it in our MDT, and they said for follow-up and just observe it. Right.
Okay, no other comments?
Thank you very much.
Thank you.
Thank you.
Thank you, Guido.
There is finish or just
yes, this is the last presentation, so we finish the section.
Guido?
We can finish the session now?
No.
Okay. Let's go to lunch.
Don't you think so? We only go
adormeço nestas reuniões, eu que adorava estas reuniões, eu compreendo o que eu estou a dizer. Tudo bem, em Buenos Aires, Argentina como está a passar, também com crise económica também, mas não como aquela, não como, não ha chegado.
Como en 2001,
sí.
Te diría igual, pero
Sí,
con menos
cosas.
agitación social.
Sí, sí, sí.
Pero tenemos 110% de inflación anual.
110.
8.8% de inflación mensual.
E como é que tu consegues viajar com isso tudo? Estás a mexer nas economias e nas coisas todas.
Se hace difícil, pero vos decís para...
Tu tens reservas tuas em dólares?
Yo tengo reservas en dólares, pero
Mas mesmo assim,
que no tengo, estoy tratando de no usarlas ahora.
claro.
No,
Y
está
es
muy difícil. Ahora en octubre son las elecciones presidenciales. Veremos qué pasa.
Quem é o presidente agora?
Ahora está Cristina Kirchner, que es una la esposa, la viuda de Néstor Kirchner. Néstor Kirchner estuvo 4 años. Después ella subió como presidente. Hizo 2 periodos.
Como é a Argentina?
Hizo
O
2
presidente
periodos.
é também o chefe do governo?
No, solamente presidente. Solamente presidente. Jefe de gobierno está solo en la ciudad de Buenos Aires, que es como si fuera un intendente. Es una ciudad autónoma. El de la ciudad de Buenos Aires es de derecha. El gobierno federal es un gobierno de izquierda.
¿De izquierda?
Es un gobierno que se dice peronista,
Peronismo de izquierda.
Peronismo de izquierda. Son los corruptos. Corruptos, mentirosos. Dicen que, para que tengas una idea, la vicepresidenta, ahora está de vicepresidente, puso a un muñeco, una marioneta, que es un inútil, y ella es la que en las sombras hace todo. Ella dice, yo soy el pueblo y estoy para el pueblo. Ella gana una jubilación de 3 millones de pesos por mes, porque cobra la jubilación, la pensión del marido muerto y la de expresidente. ¿Sabes cuál es el promedio que gana un jubilado en Argentina? Más o menos serán 120 mil pesos. ¿Qué equivale eso? 120 mil pesos deben ser más o menos $200 por mes.
¿Y es suficiente por vivir? Vivir una vida.
No, ni con una vida, no. Lo que se llama canasta básica familiar, es decir, lo que...
¿Cuánto tu familia, cuánto gastas tu familia por mes para vivir normalmente, gasolina y todo?
Más o menos Daniela y yo, porque ya los chicos viven
¿Y no
cada uno
preciso?
por su lado.
No.
Y entre los dos, los chicos
No
son
tienen,
independientes.
más bien no tienen que trabajar.
Pero Daniela y yo gastaremos
más o menos,
$500,000.
Yo consigo vivir en Lisboa con 3 libras. 3 libras. Es mi reforma. 3 libras para ver una vida normal, sin viajes, 3 libras.
Y en Argentina se necesita más o menos, se necesitarán los gastos fijos, pagar el seguro del auto, exacto, todo eso, más o menos entre $1.000 y $1.200 por, sería 1.000 euros por mes. La nafta, por
voir si ça marche. Oui. Parce que je ne sais pas.
If you want to put the laptop here, or
Perhaps
do you
better.
prefer to use?
I prefer here. Oh, that's great. It's not for now, it's just for testing. Because I want to.
You can. Enzo, mi mandi il. If you want to.
Oh, but it's right like this, it's just a test.
Mi mandi il.
Trovando fuori?
Sì. Così capisci.
Your name is Philip?
No, it's actually it's not here yet.
Which session?
Strange. No, it's I'm just tomorrow. My session is tomorrow.
For tomorrow?
Yes, I was just.
For tomorrow. Okay. We
Just to
need
try.
Just to. Sì, grazie Enzo. To change the. Sorry.
Sorry.
Okay, now he's going to.
Oh, okay.
You need the audio?
No, just checking this. It's okay. Very good.
Okay. Perfect. Can you give me your name, please, for tomorrow?
Only for tomorrow at 30. No, not for tomorrow, sorry. For the day after tomorrow.
For Saturday.
Yes. So it's here.
Okay.
And then?
So, your PC? Sorry?
It's a Mac.
Mac.
And then it's the last session here.
This one?
Yes.
Mac.
Yes. Perfect.
Okay.
Thank you.
But here you are the moderator, no?
No, I'm not. There is a moderator.
Moderator, Henri. And you and Pierre, are going to
Yes.
speak. Okay, perfect. Thank you.